Okay, think now probably everything is all right. I think so. This I'll be keeping it in my pocket. Okay. Think so. Everything is fine. I think after a series of attempts, I learned how to use it fine. I got think so. Everything is fine. Fine. Think so. Everything is fine. Okay, we are back to the work. Just updating about the morning session. Okay. Today is 8th February. Reminding myself the date also. Okay. Very cool. Wednesday is okay. That is 40 plus 20. Alexa, timer for 40 minutes.
40 minutes, starting now.
So I was reading about tetanus. It's a disease of CNS caused by neurotoxin tetanospasmin produced by Clostridium tetani. It's a vaccine preventable disease. That's why it has got so much importance. And it's a Clostridium tetani is a spore-forming obligatory anaerobic bacillus that produces two toxins, tetanospasmin and tetanolysin. Wounds and abrasions, umbilical stump are the main portal of entry for the spores and bacteria into the body. Subcutaneous injectable drug abusers using heroin by skin popping are at high risk for tetanus. Persons more than 60 years of age with immunity waning over time are at high risk. Under anaerobic conditions, tetanospasm and exotoxin released by tetany in the neurons move to the GABAergic presynaptic inhibitory interneuron. The increased circulating catecholamine levels in severe tetanus are associated with cardiovascular complications. This catecholamines, circulating catecholamines. Okay, okay, this is cool. Than keeping it dead. Let the light underline also, that's the thing. In that case, I have to figure out a way. Okay, okay. Okay, this is pretty cool then. To the pencil. Okay. The incubation period of tetanus depends on the site of injury. If the injury site is near to the central nervous system, then incubation period will be shorter. The average incubation period varies from 8 days to 1 to 2 months. Furthermore, more severe symptoms are expected if the incubation period is shorter. The tetanus can be of four types that are as follows. Okay, there are four types of tetanus. Okay, and here are the varieties. Generalized tetanus. This is the most common form of affecting the 80% of the patient. The first sign is stiffness or lockjaw and typical facial spasm. Arises salmicus is the feature. There is a diagram showing contraction of facial muscles during the tetanic spasm, followed by rigidity extending to neck, pectoral, and cuff muscles. Spasm of the trunk causes the characteristic bow-shaped form called as opisthotonus, that is arched back. Generalized muscle spasm can be very painful. Laryngeal and pharyngeal muscles are commonly involved. Spasm of the respiratory muscles results in respiratory failure. Without ventilator support, respiratory failure is the most common cause of death in tetanus. Autonomic disturbance is maximal during a second week of severe tetanus. A labile BP with rapid fluctuations accompanied by episodic variations in heart rate and even heart block can occur. Gastrointestinal stasis, sweating, and increased tracheal secretions are other common accompaniments. That was about generalized tetanus. Then we have neonatal tetanus. Neonatal tetanus occurs due to aseptic ending of the umbilical cord stump, which has not healed completely, especially if the mother is unvaccinated. Cultural practices also play a major role in this. Neonatal tetanus. And then we have local tetanus. Localized tetanus manifests as localized muscle contractions at the site of inoculation of the spore. This is often mild disease and resolves spontaneously. However, it may progress to generalized form. Cephalic tetanus is a form of localized disease affecting the central nervous system after. The diagnosis is based on clinical grounds. Culture of this Clostridium tetani from the wound site is very difficult. It's only positive in 30% of the cases and it's not helpful for diagnosis. High index of suspicion has to be maintained and treatment should be started as early as possible. Anti-tetanus immunoglobulin Gs, IVIGs, anti-tetanus IVIGs will be given. Okay. Anti-tetanus immunoglobulin G levels of more than 0.1 international units per ml are not reliable for diagnosis. Okay. Treatment is later. What they are telling to measure is serum anti-tetanus immunoglobulin G IgG levels more than 0.1 IU per ml are not reliable for diagnosis but can be considered protective if present due to immunization and stuff. Toxin assessment in serum and urine can be performed. Tetanus toxinosis. Differential diagnosis that we have to keep in mind when seeing the case of tetanus is poisoning. dystonic reactions to antidopaminergic drugs, oropharyngeal infections, hypocalcemia, meningoencephalitis. Treatment is once tetanus is clinically suspected, treatment should not be delayed till laboratory reports are available. Since the disease is mediated by a toxin, a crucial aspect of therapy is to eliminate ongoing toxin production, one thing, and to neutralize the unbound toxin. This involves a surgical debridement of the infected source tissue to eliminate the anaerobic milieu. Previously, it was recommended to administer TIG, human tetanus immunoglobulin, 3,000 to 5,000 units international, as a single IM dose, a portion of which was to be injected around the wound. Our current guidelines recommend a single dose of 500 units intramuscularly alone. Okay. Previously, a higher dose we were given, and also we used to go to local site. Now, to just a single dose, 500 units of this anti-tetanus immunoglobulin is enough. Equine-derived antitoxin is available widely but has a risk of hypersensitivity. Intrathecal administration of tetanus immunoglobulin may be helpful in the halting disease progression but does not improve mortality. Keep in mind. Antibiotic treatment involves administration of metronidazole 500 mg injection IV 6th hourly or 1000 mg metronidazole 12th hourly or aqueous penicillin G 3 million units. IV Q430. Total treatment. Spasms are controlled by heavy sedation with benzodiazepines alone or in combination with intravenous magnesium sulfate infusion. Benzodiazepines, okay, we can give magnesium sulfate infusion also for these statin spasms. That was another thing, okay. Worst cases may need neurovascular blockade with vacuum involved. Urgent endotracheal intubation to protect the airway may be needed. Laryngeal spasm may be present, which makes an intubation difficult, and early tracheostomy may be warranted in a few. Cardiovascular instability is difficult to treat. Use of beta blocker short-acting ethanol may be helpful in controlling spells of tachycardia. Tetanus infection does not confer immunity, that you have to keep in your mind. Patients who have recovered from tetanus should be fully vaccinated again. This is a very interesting point. Okay. Prevention. All children should be vaccinated against tetanus through DTaP vaccine. Your pertussis is case fever. 4 doses at 246 and 15 to 18, 246 weeks. Wait. 14, 16, I think. This is 246 and 15 to 18 months, all of it, yeah. So 246, 15 to 18 months, and a booster at 4 to 6 years of age. For adolescents 11 to 12 years of age, a single dose of Tdap is recommended for routine booster. Adults should receive tetanus booster TD every 10 years. One of the TD doses should be replaced with Tdap. For adults who have not received any primary series of vaccination in childhood, should be vaccinated with 3 doses of TD, 0, 1, and 6 to 12 months. One of these doses has to be Tdap, including diphtheria. Also, that pregnant women should receive 1 dose of Tdap, optimally between 27 and 36 weeks of gestation, irrespective of previous vaccination history. That is something we have to keep in mind, between 27 and 36 weeks of gestation. Patients with minor plain wounds with incomplete primary immunization will require a booster dose of TD. A serious contaminated wounds require human tetanus immunoglobulin in addition. Prognosis. Recovery from tetanus may take at least 4 weeks, but take a month in few. Tetanus has a mortality rate of 50% even if treated. So that's why our immunization plays such an important role in preventing the mortality associated. Next on this is under Clostridial infection is Clostridioides difficile, formerly known as Clostridium difficile infection. Clostridium difficile is an obligatory gram-positive spore-forming toxin-producing anaerobic bacillus that causes diarrhea, colitis that most often follows antimicrobial use. The bacteria are found in water, soil, meats, vegetables, and are particularly common in healthcare environments where the spores are difficult to eradicate. Infection is most frequently, more than 90% of all cases, acquired exogenously in the healthcare facility, most frequently from the environment or hands of healthcare workers who fail to practice effective hand hygiene. Community onset Clostridium difficile infection without recent hospital contact probably accounts for less than 10% of all cases. Symptomatic illness is relatively rare in India due to widespread use of metronidazole. Recently, increasing numbers of Clostridium difficile associated diphtheria. Okay, just give me a moment. This will take quite a time until most of this. Why can I put right side here? Okay. At least now I'll be in peace, I suppose. Let's see. Okay. So we were talking about something called as CDAC, Clostridium difficile associated diarrhea cases have been diagnosed in both community and hospitals in India, but underreported. That's what they're saying. Cases are underreported. This Clostridium difficile associated diarrhea cases are underreported. That one. Pathogenesis: colonization of Clostridium difficile occurs via the fecal-oral route. Following distribution of normal intestinal flora by antimicrobial therapy, the ingested spores, which are resistant to stomach acid, can germinate and proliferate in the colon, producing two major toxins. One is toxin A, which is an enterotoxin, and toxin B, which is a cytotoxin. Clostridium difficile, two toxin, toxin A, toxin B. Toxin A is enterotoxin, toxin B is cytotoxin. A third toxin, binary toxin, is produced by recent epidemic strain RP B1027, that have caused outbreaks with increased severity and mortality. These toxins produce a marked neutrophilic inflammatory response in the colon, okay, causing erosion of mucosa, lead to formation of pseudomembranes that comprise of necrotic leukocytes, debris, fibrin, and mucus that extend over the mucosal surfaces. The antibiotic most frequently implicated in this Clostridium difficile associated diarrhea include fluoroquinolones, clindamycin, penicillin, second and third generation cephalosporins. The risk is less with penicillin and beta-lactamase inhibitor combinations such as abatacaceline, clavulanate, piperacillin, tazobactam. However, most of the antibiotics, including vancomycin and metronidazole, carry risk of subsequent Clostridium difficile associated infection. Unfortunately, vancomycin and metronidazole are used in the treatment of the CDIs, Clostridium difficile, colitis, and all. Other risk factors include advanced age, more than 60 years, prolonged hospitalization, okay, greater severity of underlying illness, GI surgery history, use of electronic rectal thermometers, enteral feeding, long-term care residency, use of PPIs, prior CDI, especially severe CDI, immunosuppression, PPI use, infection with RP B1027 strain, where they told binary toxin about third type of toxin. Absence of antitoxin and antibody response are risk factors for recurrent CDI. Absence of antitoxin A, antibody response are risk factors for recurrent CDI. Clinical manifestations. Before that, there is a figure of colonoscopic biopsy specimen showing pseudomembranes which have a mucosal attachment point and comprise of necrotic leukocytes and marked neutrophil inflammatory response. In this diagram, you're able to see marked neutrophilic inflammatory response. Clinical manifestations of CDI: infection with Toxin producing strain may be asymptomatic, particularly in infants and those in long term health facilities. However, in those who develop symptoms, manifestation may include watery diarrhea. Okay, watery diarrhea. Include more than 3 episodes, as many as 20 episodes of loose stools per day. Okay, can happen. Watery diarrhea with lower abdominal pain, cramping, and low grade fever. Stools are almost never grossly bloody and range from soft and unformed to watery or mucoid in consistency with a characteristic odor. Rarely, patients manifest with features of acute abdomen with abdominal distension, then hypolimia, lactic acidosis, hypoalbuminemia, and fulminant life-threatening colitis. Diarrhea is less prominent in the fulminant form with the prolonged ileus due to cooling of secretions in the dilated atonic colon. Something diarrhea is the common clinical presentation, but still in the fulminant form, which presents with the prolonged ileus due to cooling of secretions in the dilated atonic colon, potential complications are toxic megacolon and bowel perforation. The diagnosis should be suspected in many patients with diarrhea who have received antibiotics within previous 2 months. Recurrence occurs in about 25% of the cases within days or weeks of completing treatment for Clostridium difficile. The clinical presentation may be similar to or more severe than the initial presentation. Laboratory studies, complete blood counts we have to do showing leukocytosis more than 15K, commonly found marked leukocytosis more than 20K occurs with the fulminant variety of infection. Leukocytosis, hypoalbuminemia, and elevated serum creatinine levels are markers of the severity of this Clostridium difficile associated infections. Stool-RE may show fecal leukocytosis. This present in 50% of the patients. Occult blood may be positive in severe colitis patients. Okay. And further stool assay, stool culture is most sensitive. Sensitivity is 90 to 100%, specificity is 84 to 100%, which is also slow and may lead to delayed diagnosis if used alone. Whereas test of glutamate dehydrogenase is produced by this Clostridium difficile by means of enzyme immunoassay is very sensitive. Sensitivity again is 80 to 100%, specificity of 87 to 98%. Enzyme immunoassay for detecting toxins A and toxins B have a sensitivity of 79 to 80%, but specificity is excellent, 98%. Nucleic acid amplification test, NAT test, including PCR assays, are the most sensitive single rapid tests currently available. Sensitivity ranging from 88 to 100% with a rapid turnaround time. Enzyme immunoassays for toxin A and B have poor sensitivity. European Society for Clinical Microbiology and Infectious Diseases recommended utilizing enzyme immunoassays tests for this identification of this glutamate dehydrogenase and toxins A and B two-step algorithm and resolving any discrepant results with a NAT three-step algorithm. Okay, labs used in the diagnosis: CBC, stool RE, stool CS. Colonoscopy determines test the presence of raised yellowish white pseudomembranes. Usually 50% of patients with the disease will have these pseudomembranes. They appear as raised yellowish white pseudomembranes overlying an edematous mucosa. For patients with ileus, laboratory diagnosis via perirectal swab for toxin assay or anaerobic culture may be performed, okay, for the fulminant form. Radiographic imaging of the abdomen and pelvis is warranted for patients with severe illness of fulminant colitis to evaluate for presence of complications. Treatment is initial therapy. Asymptomatically colonized patients do not require treatment. Asymptomatically colonized patients do not require treatment. In mild cases, patients without fever, abdominal pain, or leukocytosis, cessation of positive antibiotics would be the first step in treatment. The identical current epidemic strain and associated rapid clinical deterioration of some patients, prompt initiation of specific eradication therapy has become the standard. If there is a strong clinical suspicion of the CDI, empirical treatment is appropriate. Optimal hydration should be maintained, and antiperistaltic agents and opiates which may make mass symptoms should be avoided. That's very important. Hydration, optimal hydration, and you are not supposed to use antiperistaltic agents or opiates which will mask the symptoms. Going on to specific therapy and treatment. For non-severe cases of CDI, vancomycin 125 mg per oral 4 times daily for 10 days, or Pyridoxamycin 200 mg per oral BD for 10 days is used. If the previous two drugs are unavailable or contraindicated, or metronidazole 500 mg 3 times daily for 10 days may be used. That's for non-severe CDIs. Then we have for severe CDIs, either vancomycin or pyridoxamycin in the above mentioned doses. Same only. Vanco if it is for oral 125 QID, or pyridoxamycin 200 mg BD for 10 days each. Metronidazole is not used for severe CDI. That is something we'll have to keep in mind. Metronidazole won't be used for the severe CDI. Okay. Severe complicated or fulminant CDI, oral vancomycin 100 mg 4 times daily. Your dose is increased from 125 to 500 mg 4 times. And metronidazole 500 mg IV Q8 hourly for 10 to 15 days. Previously, even if we were giving 3 times 500 mg for 10 days. We are letting 4 times daily. And metronidazole 3 times only 500 mg for 10 to 14 days is the therapy of choice for this fulminant CDI. So vanco dose has been increased from 125 to QID to 500 mg QID compared to a non-severe disease, and also 500 mg injectable metronidazole we are giving 3 times a day for 10 to 14 days is the therapy of choice. Alternatively, we can use tigecycline. 50 mg injection we can use, that is gigabit injection, whatever the recurrence. This is something which have this propensity to uh, go for recurrence, this CDI infections. That's why we have to study about it. Non-severe initial recurrence can be treated with vancomycin 125 mg per oral QID for 10 days. If metronidazole was for the initial episode, we have used vancomycin now. Vancomycin taper and pulse regimen, taper and pulse regimen. What we are doing is 125 mg per oral QID for 1 week we are giving. Then we are giving for BD for another week, and then OD for 1 week. Then every 2 to 3 days for 2 to 8 weeks if vancomycin was used for the initial episode. This is called as taper and pulse regimen. It's a conversion though, so you are extending the therapy almost 3 months. Or you can also use this pyridoxamycin 200 mg BD if vancomycin was used for the initial episode. Okay, this taper and pulse regimen or pyridoxamycin is like whenever we had used this vancomycin for treatment of the last episode. If patient is coming with multiple recurrences, vancomycin, taper and pulse regimen or pyridoxamycin in those mentioned earlier are typically used for patients with more than one recurrence. Vancomycin 125 mg QID for 10 days followed by rifaximin 400 mg TID for 20 days. Rifaximin 400 mg TID, that means twice a day. Okay. Okay, for 20 days can also be used. Fecal microbiota transplantation is now becoming increasingly popular and is considered superior to vancomycin for those with multiple recurrences. Who is doing in India? Where they are doing? No idea. Fecal microbiota transplantation. Here I hadn't heard it, so I'll have to inquire about it. Prevention and control. Contact precautions with entry isolation to single room. Okay. With the dedicated toileting facilities or cohorting with other patients who have CDI should be implemented. Hand hygiene with soap and water may be more effective than alcohol-based hand sanitizers and removing Clostridium difficile spores. Since Clostridium difficile spores are resistant to killing by alcohol, disinfection of clinical areas requires use of sporicidal agents such as hypochlorite, bleach solution, antimicrobial stewardship program to reduce unnecessary antimicrobial use are extremely effective in prevention. Next on we have food poisoning caused by Clostridium perfringens. Across the CDI, we have this food poisoning caused by this Clostridium perfringens. Clostridium perfringens is widely distributed in the environment. Outbreaks of these infections are usually in institutions, nursing homes, hospitals, or schools. Meat products such as stews, casseroles, gravy are the most common source of this food poisoning. Clostridium perfringens type A causes virtually all cases of clostridial food poisoning throughout the world. That is what we have to remember. Clostridium perfringens infection often occurs when food is prepared in large quantities and is then kept warm for a long time before serving. Clostridium perfringens thrives between 40 and 140 degree Fahrenheit. Undercooked and improperly reheated food. Undercooked and improperly reheated food allows proliferation of large numbers of vegetative forms. These forms, when consumed, spoliate a thin the small intestine and release enterotoxins that are responsible for symptoms of food poisoning. This disease has a short incubation period between 6 and 24 hours. Clostridium difficile food poisoning. Incubation period is 6 to 24 hours. Symptoms include watery diarrhea. Okay, interesting. Abdominal cramping, fever, and vomiting are less common. And the symptoms will be resolved spontaneously within 24 to 48 hours. Diagnosis is identification of the bacteria can be done by culture methods and toxin detection. The recommended specimens for organism isolation for suspected food are stool from affected patients. Okay. Toxin can be detected in feces if you perform a test. A colony count of more than 10 raised to 5 CFU per gram, whatever sample you are taken, and detection of toxin genes suggest infection by Clostridium perfringens. Okay, now we have other Clostridium infection, including botulism. A short note. After that, we'll be going to gram-negative infections. Intestinal malignancy and IBD, inflammatory bowel disease, increase the chance of Clostridium infections. So Clostridium perfringens is the most commonly associated Clostridial species. Non-traumatic gas gangrene, which occurs in the absence of external wound, principally caused by this Clostridium septicum. So non-traumatic gas gangrene occurs generally via bacteremic route in the setting of neutropenia and GI pathologies such as colon cancer, diverticulitis, and bowel perforation and biliary tract infections and necrotizing enterocolitis. It progresses rapidly and may be more fulminant than traumatic gas gangrene due to Clostridium perfringens. Mortality is as high as 60 to 100% in this Clostridium septicum non-traumatic gas gangrene infection. A short note on botulism. Botulism is a toxin-mediated neuroparalytic disease caused by Clostridium botulinum organism. Botulism is of three types. One is food-borne botulism. Second is infant botulism. Third is wound botulism. Food botulism is associated with home canned or fermented foods. Home canned or fermented foods. IV drug abuse is associated with the wound botulism. Botulism is a potential bioterrorism agent spread through aerosol or ingestion. Etiology and pathogenesis. Seven serologically distinct serotypes of botulinum toxin, that is A through G, have been confirmed. Steps in neurotoxin activity is given in this figure, and release of acetylcholine releases in blood that affect the cranial nerves in a symmetrical fashion and later involves voluntary muscles. So heavy chain binds nerve terminals of this toxin. Heavy chain binds nerve terminals, so causing endocytic vesicle internalization and causing translocation of the light chain to the cytosol. And then cleavage of proteins involved in the release of acetylcholine. Cleavage of proteins involved in the release of acetylcholine. Because of this, there is excessive acetylcholine release. Or what exactly pathogenesis stories? Heavy chain binds not onus, endocytic vesicle internalization, translocation of the light chain to cytosol after the cleavage of proteins involving the release of acetylcholine. So if you inhibit the cleavage of proteins which are helping for the release of acetylcholine, actually it is the lack of action of acetylcholine which is driving the pathogenesis of this disease. Okay, that's what they had written is release of acetylcholine is blocked. Okay, that affects the cranial nerves in a symmetrical fashion and later involves voluntary muscle too. Clinical features, signs and symptoms appear after 12 to 36 hours after ingestion of food contaminated with this preformed botulinum toxin. Diplopia, dilated and fixed pupils with the ptosis are characteristics features. So diplopia with dilated and fixed pupils, that is something which we have to be looking in a patient of this botulism. In a few occasions, there can be involvement of other cranial also. Other clinical features include dry mouth, dysphagia, dysphonia, etc. Respiratory failure and death due to progressive paralysis may also occur. Differential diagnosis. GB syndrome Miller-Fisher variant, which will mainly present with ophthalmoplegia, diplopia presentation, which we are allowed to keep in mind. And also, another differential diagnosis for this botulism is myasthenia gravis and tic paralysis and Lambert-Eaton syndromes. Labs which we have to consider for diagnosis of this botulism includes you can use samples of serum, stool, contaminated food which was ingested. The organism can be isolated from stool and wound cultures. Clinical specimen should be collected early as toxin assay results may be negative if delayed more than 7 days after symptom onset. A negative result does not exclude this diagnosis if clinical suspicion is strong. No condition studies and electromyography can also aid in diagnosis. Treatment is administration of this botulinum toxin and medical intensive care management or the cornerstone of hospital therapy. The treatment must be given as early as possible as antitoxin have maximum effect only when the toxin is still free and not bound to the nerve endings. It neutralizes free toxin which is yet to be binding to this nerve endings. It does not reverse existing paralysis. Already in the United States, there are two licensed antitoxin products. Equine serum ethylene botulinum antitoxin is used in children older than 1 year of age and adults. Then we have this human-derived botulism immunoglobulin is used for infants less than 1 year. So human-derived we can use in even younger childs, like infants, less than 1 year age we can use. Okay, infants less than 1 year age we can use this human-derived botulinum immunoglobulins. Whereas this equine derived though after 1 year and in adults only we can use. Intravenous human derived botulism immunoglobulin that is called as baby beak is used for infant botulism. The role of antibiotics in botulism is controversial. However, penicillin and metronidazole have been frequently used. Aminoglycosides and tetracycline may aggravate the condition as they inhibit the neuronal calcium entry, so they are not indicated here. So if you're using antibiotics, it's penicillin and metronidazole. This is quite a good and interesting chapter because so much clinical infections which we studied. I just want to revise this table 1 which they had given spectrum of this Clostridium infections. So Clostridium confringens can cause capital soliditis, myositis, Clostridium myonecrosis and hemolysis, etc. The toxin which is produced by this Clostridium perfringens is mainly alpha toxin, which is basically phospholipase, and also we have theta toxin and others. Clostridium septicum causing this gas gangrene, tissue necrosis, hemolysis. Its toxins are alpha toxin, beta toxin, hyaluronate is gamma toxin, and septicolizin delta toxin. Food poisoning, we have Clostridium perfringens type A causing food poisoning through enterotoxin, and we have Clostridium perfringens type C causing enteritis, necroticans through beta toxin, and we have Clostridium difficile causing antibiotic associated colitis through toxin A and toxin B. Toxin A is antirotoxin, toxin B is cytotoxin. Okay, and we also have this newer strains producing this Clostridium difficile binary toxin. We have this Clostridium septicum causing neutropenic enterocolitis by unknown mechanism, possibly beta toxin may be involved. And then we have this Clostridium septicum implicated in the etiology of this colorectal cancer, so we don't know the mechanisms yet. Then we have this Clostridium perfringens, remorse, and many others causing abdominal infections, cholecystitis, peritonitis, ruptured appendix, and bowel perfusion, etc. Through this necrotoxin called beta toxin, remusum and perfringens. Then we have this mainly Clostridium tetani causing tetanus through tetanospasmin toxin, and we have Clostridium botulinum causing botulism through botulinum toxins. So this was this gram positive infection. Quite a chapter though. So we had in detail dealt with this Clostridial infection, and also we studied about diphtheria. Enterococcal infections was very interesting indeed, because we see in clinics more often. So about pneumococcal vaccine, especially about vaccination, it was a highlight. Pneumococcal and streptococcal infections and staphylococcal infections are a bit of I don't know, requires revision. Okay. Okay. Let's move on to our interesting gram-negative bacterial infections. In that first chapter being meningococcal infections, written beautifully by respected Neha Gupta and Ashish Joshi. Introduction. Meningococcal disease was first described in the late winter and spring in Geneva, Switzerland in 1905. Alexa, stop. This was my 40 minutes timer. I am using Pomodoro technique for studying, where I study 40 minutes and then take 10 minutes break, you know. So my second block for the day it is. I'll just take a short break anyhow. So I can just do this. Getting camera, smartphone. I'll just do from camera to on. I can do this too. Just like off the video for a bit. Okay. I got if I off, it's not going to matter. Okay, I think my break time is over. Let me fix this a little bit. Okay, I think this is to camera settings. Okay then. Let's move on to study this meningococcal infections. First gram negative infection, what should I have written? And the section, okay. Alexa, 40 minutes countdown timer.
40 minutes, starting now.
Neisseria meningitis is an obligate human pathogen with no other reservoir. I think I got my skull probably. The major valence factor in Neisseria meningitis is polysaccharide capsule. Okay, remember that. Okay. I think I got a famous call. Let me think. audio is supposedly fine only. I don't know why this thing is telling me like that. Mhm. I think it's fine. Outro has been recorded continuing nicely, so I'm not going to worry about the audio part again. Okay. In India, we have Sirogute most common. CBWI also documented. Alexa, stop. Alexa, stop. I think we'll take a break.